Okay, well, we've been talking about the endocrine system, and in section 2 or part 2, we revealed the structure of the pituitary gland, and we talked about the hormones of the posterior pituitary, ADH and oxytocin. Now we're going to delve right into the hormones produced by the anterior pituitary gland and learn how they're regulated by the hypothalamus. So here's the diagram we saw that showed that nuclei, clusters of neurons in the hypothalamus, release neurotransmitter into blood vessels that travel to the anterior pituitary by the hypophyseal portal system, some specialized blood vessels. And then those hormones, once they arrive, trigger the release of these hormones from the anterior pituitary gland. So these are the hormones of the anterior pituitary gland: growth hormone, thyroid stimulating hormone, adrenal corticotropic hormone, follicle stimulating hormone, luteinizing hormone, and prolactin. 4 of these hormones are called tropic hormones because their function is to activate other endocrine glands. So thyroid stimulating hormone, not too hard to conceive that it activates the thyroid. Another name for thyroid stimulating hormone is thyrotropin, because it is an activator of the thyroid. And we'll find out that that's an important thing to realize, that naming scheme. Adrenocorticotropic hormone is also called corticotropin. And these two are called gonadotropins. So those names, as you'll see, will come up again. Many of the hormones are regulated by negative feedback. So we see the hypothalamus releases thyrotropin releasing hormone. So now you see that name comes into play. TSH is also called thyrotropin. So thyrotropin releasing hormone causes the anterior pituitary to release thyroid stimulating hormone, or thyrotropin. That in turn causes the thyroid gland to release thyroid hormone, which then acts on its target cells. Thyroid hormone, as it builds up in concentration, feeds back and inhibits the release of TSH from the anterior pituitary gland, and feeds back and inhibits the release of thyrotropin releasing hormone from the hypothalamus. And that shuts off the production, so it stays at a constant level. If the level starts to decline, then we disinhibit these two pathways, and the hypothalamus and pituitary start releasing those stimulating hormones again, and we get more thyroid hormone. Let's take another look at a deeper look at some of the hormones. We'll actually breeze through a couple of the hormones in a bit, and we'll hit pretty hard on growth hormone and thyroid hormone in this part of the exercise. Growth hormone, which is oftentimes in your textbook even called human growth hormone, which I just don't have any idea why they do that. We're talking about the human body. Anyway, growth hormone is a peptide hormone that is controlled by the hypothalamus releasing growth hormone releasing hormone at the appropriate time, or when we don't want any growth hormone, the hypothalamus releases growth hormone inhibiting hormone. Whoops. I have a little typo in here. I should say inhibiting hormone. I promise to correct that. Growth hormone is elevated in children and throughout adolescence, and it is responsible for the increase in stature and dimensions of the body during development. So that's one function of growth hormone, that once in a lifetime growth phase. Another thing that growth hormone does, though, is it rises during exercise in everyone. It's important for mobilizing the fuels, the molecules that your muscle cells will use for producing ATP for muscle contraction. Okay, yowza, look at this slide. The main thing I want to highlight on this slide, first of all, to show you that it's just reiterating what we saw in the previous slide. Growth hormone causes growth of the skeletal, musculoskeletal system, and the extraskeletal system during the development phase of the lifespan. During exercise, growth hormone is also released, and during that exercise function of growth hormone, it causes the release of fatty acids from fat, and therefore its use in muscle cells for energy production, and it causes the release of carbohydrates, glucose, into the blood from glycogen stored in the liver, for example. So it frees up and we say mobilizes, makes available those fuel sources for muscles to produce energy. But back to this growth in the stature of the body and dimensions of the body, it's an indirect function. Growth hormone triggers the release of a growth factor, insulin-like growth factor, or a family of them from the liver and some other tissues. And it is those signaling molecules that actually bind to receptors on various organs and structures in the body that cause them to grow. So if I ask you that question, it's not a trick question, I want you to remember that growth hormone is not the arbiter of increases in size of these organs and structures. It's insulin-like growth factors, IGFs, that actually do it, but that is in turn induced by growth hormone. So you can see there's this two-step process here. If you have too much growth hormone in children during that growth phase, they'll grow too much, and you'll have someone with enormous stature will be the result. And here you see this congenial fellow who lived for many years as a novelty show member, and he would travel around from town to town with a group of other people and allow people in the villages and towns to see what it looks like when someone has gigantism. If you continue to have oversecretion, or if you have oversecretion exclusively in adulthood, you'll have a condition called acromegaly. We'll look at that in a second. Hyposecretion during development, during childhood, results in pituitary dwarfism. And here's a fellow who has pituitary dwarfism. Here's a person who was invited to join this picture because she's of a typical stature. And here you can see how small this guy is, this pituitary dwarf. There's other forms of dwarfism, which we'll bump into in a little bit, that are more common and probably therefore more familiar. This guy has perfectly normally proportioned body parts and regions, but he's just smaller. Acromegaly, the sustained secretion, oversecretion of growth hormone in adulthood, results in continuing growth of bones in the extremities, for example. And you can see the change in this woman's hands over years of time with overproduction of growth hormone, and the bones of the face, for example. Here's a classic look of someone with acromegaly, and it's something that's recognizable. If you Google acromegaly and look for images, you'll see quite a few images pop up, and they have characteristic look of the overgrowth of the facial bones that you see there in that individual. Okay, so that's our introduction to growth hormone. Let's look at adrenal corticotropic hormone. We're just going to look at this briefly. We'll later spend some more time looking at its product, cortisol. So adrenal corticotropic hormone is triggered from the anterior pituitary gland by corticotropin releasing hormone from the hypothalamus. Right? This is corticotropin, its other name, and here's the corticotropin releasing hormone causes it to come out. So it's regulated by negative feedback, and in fact this hormone has a fairly noticeable diurnal rhythm. It changes in concentration throughout the course of each day. But I'd like to also point out that stress and intense exercise can also trigger the release of corticotropin releasing hormone and ACTH. And therefore, what's the final part in this hierarchy? Cortisol. Cortisol comes from the adrenal gland, the adrenal cortex, in response to ACTH. So when you're stressed or when you're exercising vigorously, cortisol helps your body respond to those needs, to those challenges. You need cortisol to be able to rise to the challenge. Like growth hormone, as we'll see, it'll help promote mobilization of fuels, among other things. Gonadotropins, follicle-stimulating hormone in males and females, promotes gamete production. What causes its release? Gonadotropin-releasing hormone from the hypothalamus. Right, so this hormone is going to activate the gonads, and so it's called gonadotropin, and therefore its release is triggered by gonadotropin-releasing hormone. I think they put the little N in here so that there's no way to confuse it with growth hormone releasing hormone. Make sure you didn't mess that up. So gonadotropin releasing hormone. Luteinizing hormone is another gonadotropin that's also triggered by gonadotropin-releasing hormone, and it promotes the secretion of the gonadal hormones, estrogen and testosterone, those hormones that are responsible for the secondary sex characteristics and fertility of the body. So these two are the gonadotropins. Prolactin is not a tropic hormone. It promotes breast development, and it also promotes lactation. You can see the word lactation right in there. Prolactin. So it is stimulated by suckling on the nipple, and then it will cause the production of milk so that as needed, it will be produced and be available. Oxytocin will help move that milk anteriorly so that it's available for access by the infant. Incidentally, prolactin is carefully regulated. Men, for example, do not produce any prolactin because their hypothalamus produces prolactin inhibiting hormone, and so they don't release prolactin. So prolactin releasing hormone is only released from the hypothalamus when suckling takes place and during development. Sometimes a tumor may arise that causes excess prolactin production. It'll interfere with some various processes in the body. It'll promote lactation in the breast. It'll inhibit the menstrual cycle, cause infertility in females right if the menstrual cycle isn't processing. It means we're not having the normal rise and fall of progesterone, estrogen, and impotence in males. So one of the things that's always tested, if there's a complaint of impotence in a otherwise normal man, you might check for prolactin levels and see if there's an abnormally high prolactin level. Okay, let's just take a look at the thyroid gland. We're going to take quite a close look at the thyroid gland real quick and thyroid hormone. So we've talked about the hormones of the anterior pituitary gland, and now we're moving down to the target glands and target tissues of those hormones. So here's the thyroid gland, the spongy gland, kind of the base of your neck. You can see your Adam's apple, your larynx here, and your trachea, and it's a funny construction. The anatomy of the thyroid gland is such that there's large spherical hollows surrounded by epithelial cells all throughout the thyroid gland, and those hollows are called follicles, and they're filled with a protein called thyroglobulin. The stuff in here is also called colloid. So we got this protein that's being secreted by these epithelial cells. Let's take a look at how the thyroid gland does its thing. The thyroid gland releases two forms. T4, this hormone is known as thyroxine, and we'll get all into what is T4 in a second. There's two iodinated tyrosines. And there's also another form called T3, triiodothyronine. Let's go on to the next slide so we can see what is the difference between those two? How do they come to be? So this diagram is going to allow us to follow the course of production of some thyroid hormone. So the first step in producing thyroid hormone is the transport of any iodide ion. Iodine is I2, and iodide ion is this I- ion that comes from your diet. So iodide ions come in from your diet from eating like iodized salt and potatoes, and it's transported aggressively into the thyroid gland. Iodide does not remain in the circulation. It's quantitatively transported into the thyroid gland. And then it's transported into the follicle by the epithelial cells, and it's used to iodinate, attach iodines onto tyrosine amino acid side chains within that thyroglobulin protein, within the colloid. Right? So these little sticks aren't quite chemically correct. It should be a peptide chain or a protein. And we've now iodinated a couple of tyrosine residues here and there, sometimes with one or sometimes with two iodines or on those rings. And then when thyroid stimulating hormone is binding to receptors on the thyroid gland, then we start chopping, linking together pairs of these iodinated tyrosines and trimming them out of the protein so that we truly do just have two little sticks, which represent what's left of the tyrosines and the iodides. The iodines are on there. And then we'll transport those things. Oops, before I decided to put in a slide showing you what I mean by that process. Here is a thyroglobulin protein, and we've just drawn in a couple of tyrosines. This is what the side chain of tyrosine looks like. It's got like a ring structure, an aromatic ring structure on there. And there's enzymes in the in the epithelial cells that can add iodides onto these rings. And so now we have iodinated the tyrosines, and then the finishing up of the hormone involves linking together pairs of these tyrosines with the iodides on there, and then trimming the whole thing out of the peptide chain. So that's really what thyroid hormone looks like. Just these two rings with iodides on there and cut out of the protein chain. So anyway, yeah, we're gonna trim those out and capture them by endocytosis and transport them to the cell surface and secrete them into the bloodstream, hormones, right? That's the whole process of making these two hormones, T4 and T3, thyroxine and triiodothyronine. T3 is 10 times more active than T4. This is the actual active form. T4 is not so active, but it's the main secreted form. So 4 iodides on here is how it comes out from the thyroid gland for the most part into the blood. And in the tissues, in the target tissues, there are enzymes that can remove one of these iodides off of here. And we wind up with this very potent thyroid hormone then that can operate on receptors in that tissue. How do we regulate thyroid hormone? By negative feedback, just like we saw in that slide that was used as an illustration of hormone regulation. So again, if thyroid hormone levels rise, it feeds back and inhibits the anterior pituitary gland and hypothalamus so that these regulatory hormones are not released. If thyroid hormone levels go down, then these stimulating hormones go up and bring up thyroid hormone production once again. So thyroid hormone remains constant all the time, except during pregnancy and severe hyperthermia. If your body temperature really starts to drop, you've somehow been stranded out in the cold, your thyroid hormone levels will rise to help drive up the metabolic activity of your cells, because that's one of the things thyroid hormone does. It enhances the functions of epinephrine and norepinephrine, which in turn control the metabolic activity of your cells. How much ATP are they burning through and how much heat are they releasing? That's that same chart we saw again, showing the negative feedback regulation of thyroid hormone. So what does it do? Again, it's a metabolic hormone. It determines the basal metabolic rate of your cells. It drives up the rate at which the sodium-potassium pumps are cycling and burning through ATP and releasing heat. So if you have a lot of thyroid hormone, you have a lot of metabolism. If you have low thyroid hormone, you have lower metabolism in your body. Thyroid hormone is permissive and necessary for many aspects of fetal and infant development. So you've got to have thyroid hormone. If the mother during pregnancy is hypothyroid, some of the processes of development in the womb are going to be delayed, but it's okay as long as that the baby, once born, can produce significant amounts of thyroid hormone. It'll catch up and it'll have a normal development. But if there's insufficient thyroid hormone during infancy, that's a different story. Also, as I mentioned, thyroid hormone is permissive for norepinephrine and epinephrine. Everything they do more of in the presence of thyroid hormone. And growth hormone as well. You need thyroid hormone for growth hormone to do its thing. So what if you don't have enough thyroid hormone? Well, you'll have reduced metabolism. I'm getting ahead of myself. Why would this happen? Causes of hyposecretion of thyroid hormone. It could be due to a lack of iodide ion. If you go back to our chart, our diagram of how thyroid hormone is produced, if you can't iodinate those tyrosines, you've got nothing. You can't make thyroid hormone. So people that live in geographic regions where there isn't iodide ion in the environment, and therefore not in the food, they may develop hypothyroid. The most common cause of hypothyroid is an autoimmune disease called Hashimoto's disease, in which your immune system mistakenly attacks and destroys the thyroid gland tissue, and so that there isn't enough thyroid hormone being produced. Also, you could have maybe cancer and forced to remove that gland, or people that have hyperthyroid, as we'll see in a second, are often treated by destroying the thyroid gland. So in all these cases, we have hypothyroid. What symptoms would we see if we were not treating that condition? Weight gain, right? If you're in a habit of a certain amount of food and calories you eat every day, and suddenly you have lower metabolism because of less thyroid hormone, you're going to gain weight. It makes your skin thick and dry. You have chills, right? You're not producing enough heat. You're not producing enough energy, so you start to feel uncomfortably chilly. You have puffy eyes, just sort of swelled around the eyes. Lethargy, which means feeling wiped out, no energy. If the status, the thyroid hormone status is caused by low iodide, and I shouldn't say iodine, I should say iodide with a D, the ion, in the diet, then a goiter may be produced. We'll take a look at that in just a second. If there's not enough thyroid hormone during infant development, then cretinism will result. It's a permanent, severe failure of nervous system development. Severe retardation and all kinds of other anomalies of development will occur in the absence of thyroid hormone. So consequently, for that reason, in this country, every single baby that's born in this country will immediately have its blood tested for thyroid hormone. If there's not enough thyroid hormone, it will immediately be supplemented in order to prevent this terrible outcome. So we treat hypothyroid with hormone replacement therapy. Sounds great. It's really tricky to get just the right amount of thyroid hormone in pill form into the body so that the patient feels comfortable and has normal function. So it's quite a tricky thing, and also sometimes after you've been taking thyroid hormone replacement therapy for years, all of a sudden you start feeling really bad and things aren't working out, and you have to go back for a recalibration of your thyroid hormone dose, your replacement dose. What's a goiter? Well, let's think back to this slide. Oops, can't get it to stop, my thumb wheel. If we don't have any thyroid hormone being produced, right? If there's no iodide in the diet, then there's no feedback here, so ignore those dotted lines. There's going to be whopping amounts of thyrotropin-releasing hormone, whopping amounts of thyroid-stimulating hormone produced, and they're going to all the thyroid-stimulating hormone is going to be constantly attacking, not attacking in a bad way, but trying to fire up the thyroid gland to produce thyroid hormone because there isn't any coming out. But it can't. And so what eventually happens is the gland begins to hypertrophy. It starts to grow as if maybe the problem is we don't have enough gland tissue. We'll just try that. And so the gland begins to grow, and here's a little goiter forming. A goiter can be very, very large indeed if it's allowed to continue to grow for a long time. So people, again, that live in areas where there isn't iodide ion in the landscape, they have a goiter forming. In this country, one of the first things, and one of the great success stories of the public health system, the Food and Drug Administration, was to have industry adopt the addition of iodide ion to salt. Salt is cheap to make and cheap to add iodide to, and everyone needs salt and buys salt, and so it was a great way to supplement iodide ion for people in parts of the country in the Southwest, for example, where there just isn't any naturally occurring iodide, so that we didn't want there. Previous to that, there were lots of problems with hypothyroidism. And so that was ameliorated by just that's why you see iodized salt in the grocery store. And you should buy iodized salt because you want to make sure you have plenty of iodide in order to produce the thyroid hormone that you need. Hyperthyroid, one of the hallmarks of hyperthyroid is exophthalmos. Now we haven't come to that. Oh, I skipped over this slide to get to the goiter, I guess. I didn't even notice I did that. Oh no, here we are. Hypersecretion of thyroid hormone, or hyperthyroid, can be caused also by an autoimmune disease. That's only one cause of it. Sometimes people just immediately assume the cause of it is called Graves' disease. That's the most common cause. Your body produces antibodies. Now get this, the antibodies don't damage the gland. They bind to the thyroid-stimulating hormone receptors, and the gland thinks that TSH is out there. Antibodies act in such a way to mimic the effect of TSH, activate those receptors, trigger the production of thyroid hormone. So, but it's fairly common for people's thyroid gland just to start growing and producing too much thyroid hormone. And they have hyperthyroid. In fact, thyroid cancers, which is just another sort of stage in overgrowth of the thyroid gland, is also fairly common. And it's a really fascinating story in a way. It's a bad problem if you have hyperthyroid. What are you going to do about it? Well, if you have thyroid cancer, you really have to get the thyroid gland out. If you have hyperthyroid, we'll see in a second, there's a way to treat that, a different way to treat that, so it's relatively easy. But if you have to get the gland out, it's a very, very difficult surgery. And the most famous, probably some of the arguably the most famous medical institutions in America arose around doctors that pioneered a successful surgery for removing the thyroid gland. Previously, people would basically die of complications during attempts to remove the thyroid gland, and finally these guys succeeded in a strategy for surgically removing the thyroid gland. Cleveland Clinic and Johns Hopkins University Medical Center are both institutions that arose around people coming from all over the world to have their thyroid, their cancer, treated in this way, because they had perfected this very tricky operation. That's fascinating history about it. The more common way to treat, I don't know if it's coming up on another slide, it's not. The most common way to treat hyperthyroid is to infuse into the body a radioactive iodide ion. It's toxic radioactive stuff, so that these iodide ions are releasing high energy radioactive emissions, which destroys and kills cells. But remember, the thyroid gland is so aggressive in its transport of iodide ion from the blood that you can safely inject radioactive iodide ion into the blood. It will be immediately sequestered in the thyroid gland, and where it will reside, and all the discharge of radioactive decay will kill all the cells of the thyroid gland. It's called ablation. Ablation. And then, of course, you'll have to be treated by thyroid hormone replacement therapy, just like someone who had hypothyroid. Anyway, if you have too much thyroid hormone, you have excess metabolism, increased heart rate. Anything epinephrine and norepinephrine do, right? They increase your heart rate during exercise. Boom. Increased heart rate, increased blood pressure, hypertension, anxiousness, nervousness, jitteriness, because there's so much, all your neurons are just metabolizing too fast, too much. Weight loss, if you're, again, in the habit of eating a certain amount of calories per day, now you're metabolizing more, you're going to lose weight. And exophthalmos, as we just got a sneak preview of, it causes edema behind the eyes in the orbit, which causes the eyes to be pushed forward, and eventually some scar tissue will form in there, and you'll see this bulging eye phenomenon. And that's a characteristic look of someone who has hyperthyroid that's been untreated for a significant period. And you may encounter people like this in your clinical travels. Calcitonin. If you look in the book, you'll see that calcitonin is a endocrine cell type that's in the thyroid gland that produces a hormone called parafollicular cells in your thyroid gland will produce a hormone called calcitonin, which causes bones to deposit more calcium phosphate hydroxyapatite into the extracellular matrix of bone. It's possibly important during childhood development, but it has no significant role in adults, so I generally don't even talk about it. I don't expect you to worry about it. But I guess just for full disclosure and for your own education, there is a hormone called calcitonin that promotes bone density. The parathyroid glands, we have mentioned them, and we've seen them in chapter 6 when we talked about bones and bone tissue. So here we're looking at the posterior of the thyroid gland in your neck, and on the back there's these islands of parathyroid gland. It's a totally different tissue, unrelated to the thyroid gland. And if blood calcium goes down, that's called hypocalcemia. This is something important to emphasize. When you see that EMIA suffix, that means in the blood. So hypocalcemia means low calcium in the blood. That causes the parathyroid gland cells to release parathyroid hormone, which promotes an increase or a restoration of calcium levels by three means. One is by causing osteoclasts, as we saw this morning in the bone tissue lying on the surface of the bones under the periosteum, to dissolve away some bone matrix and release calcium and phosphate into the blood. In addition, parathyroid hormone causes the kidneys to retain calcium from what's going to become the urine. So reabsorbing back calcium into the body so that we don't pee out any calcium when we're short on calcium in the blood. And finally, activating vitamin D synthesis in the kidneys so that we are able to absorb any calcium in the diet. Got to have vitamin D to get that calcium. If you have too much parathyroid hormone, if you have a tumor that's producing parathyroid hormone, this is life-threatening. And it also deforms your bones. You'll have the osteoclasts being overactivated, taking too much extracellular matrix, too much ground substance out of the extracellular matrix, and that's what makes bones hard and stiff. And so they won't be hard and stiff. They'll start to soften and deform and break. Also, elevated calcium levels are incompatible with normal nervous system and muscle cell function, because we know that calcium is an important signaling molecule in these tissue types, and having too much calcium outside the cells means that the calcium is going to sort of force its way by diffusion into the cells, and it's going to interfere with normal function of the cells. So that's bad. Also, if you have too much calcium and phosphate in your blood, it can precipitate, meaning come out of solution into like a crystal form, chunky, minerally kind of crystal formations, and they're called kidney stones. They can occur elsewhere in your body, but kidney stones are particularly painful, so they brought it up here. So that's bad, very, very painful. If you have hypoparathyroid, if you have no parathyroid glands, you'll die. You have no way to regulate calcium. Again, it's a critical signaling ion. It's what controls muscle contraction in your skeletal muscles, but especially your heart, right? You'll die from not having control of muscle contraction in your heart. But as you just have, as the level just starts to decline, you'll have tetany, which means spastic muscle contractions, unwanted muscle contractions, strangely, paralysis of the respiratory system, and eventually death. So, important stuff. How important are hormones? Very important. Now we come to the adrenal gland, and the adrenal medulla, the inner part of the gland, we've already encountered in chapter 14. It's where the sympathetic nervous system triggers the release of epinephrine and norepinephrine into the blood during exercise or during traumatic emotional conditions, and so that's where those adrenalins come from. The adrenal cortex is the outer part of the adrenal gland, and it releases steroid hormones. We said steroid hormones come from the gonads and from the adrenal cortex. So that's what we're talking about here. Corticosteroids, they're also called. Cortico, the source, and steroid hormones. So in the next section, that's what we're going to pick up and talk about the corticosteroids and what they do, how they're regulated. Some very interesting stuff right there. So join me for part 4.